Professor Emeritus, Department of Chalyatantra, STMC would be to take over the session. Welcome, sir.
We'll start with the point where we had left last time. The clinical signs, ancillary signs, which can be seen in case of neurological conditions. Among them, one more is a Palin sign. Palin sign is if you just the dorsiflex the palm hand and then keep them together, the patient may have a feeling of paresthesia and pain in the wrist area. This is sign of carpal tunnel syndrome. This is called as a Palin sign as such. That's one more of the clinical sign in neurological conditions. Then the Halpic or Neelan-Barry's maneuver is another of the clinical sign which is often used in case of neurological conditions, again which is somewhat non-specific. This consists of the patient has to lie back in the bed initially, and then maybe you just turn the head. The position has to be changed to 45 degrees to the left and the right, or it also can be done in a sitting posture as such. Now when you do this, they rotate the head in the different positions. If the patient develops the giddiness, a feeling of a vertiginous discomfort or giddiness like and nystagmus, that's a sign that the patient may have either neurological conditions like central lesions. The issue is in case of the central lesions, the nystagmus may occur in the head turn to the either side in any of the situations as such. That's another clinical sign which is often elicited in case of the neurological conditions. Then benediction hand is another of the sign. Benediction hand sign is usually sign of peripheral neuropathy affecting the muscles in the hand, and is in the patients who, when you are asked to make the patient close the fist, the ring and little finger flex, but the index and middle finger cannot flex at that metacarpal phalangeal joints or interphalangeal joints. These two fingers cannot flex in that condition. That's a sign of a peripheral neuropathy affecting the hand as such, particularly nerve injuries. This can happen. Then Koscheck sign is another of the sign, which is usually a sign of hypocalcemia, and it can be elicited in two ways. One, by tapping on the cheek, by hitting on the cheek, you will see that there will be tetanic facial contraction. There can be contraction as such, or this also can be seen by facilitating the contractions or hypocalcemia by tying a BP apparatus cuff over the area and raise the pressure between the arterial and the venous pressure, so that there is a venous stasis, and the stasis of the blood flow will reduce the calcium level further in the muscles, which results in the contractions, which is also called as the obstetrician sign. The finger take the shape as is that of a obstetrician holding the presenting part of the baby. This is also called as obstetrician sign as such. So that's about the clinical signs related, certain of the clinical signs related to the neurological conditions, and particularly hypocalcemia induced tetanic contractions, they can be elicited. Then milkmaid's grip is another of the clinical sign, which is often seen in case of chorea, patients of chorea. When you ask the patient to hold two fingers of the examining physician, if the patient cannot hold it sustainably, there will be once the patient holds, then relaxes, holds and relaxes, sustained grip is not seen. That's a sign of the chorea, possible underlying chorea, and it is called as a milkmaid's grip. Then Beaver's sign is a situation where the patient may have a muscular dystrophy, or it also could be in abdominal muscle paralysis. Usually, when a person raises the head up, the umbilicus would be moving downwards due to the contraction. But in the patients who have a paralysis, the umbilicus would be moving upwards in patient, and that's called as Weaver's sign. And this is suggestive of either muscular dystrophy conditions, or even in case of paralysis of the abdominal muscles. And this is another of the clinical sign as such. Then big shock sign is another of the condition where the patient,
So,
when
screen is not visible, sir.
screen is not visible.
Yes.
Now is it okay?
Yes, sir.
Ah, I think earlier signs also you couldn't see that. Fine, okay. Now, Bilshowitz sign is where the patient, when the patient's head is tilted as such, there would be a oblique movements of the eyeball. Eyeball may move in opposite direction, which results in diplopia. Patient will not be able to see the vision clearly, and the eyeballs will be moving in opposite direction, which is again a sign of the trochlear nerve palsy. This is another of the clinical sign which is often seen in case of neurological pathology. Gover's sign is in case of the muscular dystrophy, where if you ask the patient to get up from a sitting posture, patient would not be able to get straight up. Instead, the patient forms initially supports on four legs, then forms a triangle-like shape, then attempts to get up. And this kind of a typical appearance is a sign of muscular dystrophy. Patient keeps the foot apart, the gap between the 2 feet would be quite far off. This is very typical of Duchenne's muscular atrophy, where the calf muscles should be bulged as such. That's another of the sign, characteristical sign in case of neurological conditions. Then jaw jerk is an exaggerated jerk by eliciting the hitting upon the jaw area, keeping a finger over there, and it's usually normally it's a smooth contraction scene. That, but there can be a increased reflex activity, particularly in patients who are having a stress and increased cortical activity. Increased cortical activity, there will be an exaggerated reflex as such. That's another of the clinical sign which is seen. Then Lermite sign is a condition where the patient feels an electric shock like conditions, particularly when the head is bent forwards. This is typical of multiple sclerosis. Multiple sclerosis, or even it can occur in case of the spondylitis conditions where the nerve tissues are injured. The stress on the nerves could be enhanced by bending the neck forwards as well as raising the leg up, so that there will be more stress gap between the two spines will be reduced further in the neck area, and the patient may feel acute pain, which is something like felt like a current shock like sign. That's the Lermite sign, which is often seen in case of spondylitis or sclerosis like conditions, multiple sclerosis like conditions. Then Tullio phenomena is a situation where the patient may have a nystagmus as vertigo when when there is a sudden sound formed around the area. If the patient is some sudden sound is produced, like a loud sound, like a clapping behind the head would be produced. Patient should not see that clapping activity. So if you clap that, that produces a nystagmus, and that's called as a Tullio phenomena, where the patient may have the cochlear apparatus affected, not so a vestibular, the cochlear apparatus being affected, and particularly irritation of the vestibulocochlear component, and where the cochlear apparatus is affected, a sudden sound produces a nystagmus, and that's called as a Tullio phenomena, which is usually seen in case of the superior canal. Pathologies of the superior canal also it can occur in such conditions as such. Then Tinel sign is another of the sign where by percussing or hitting upon the nerve would elicit a tingling sensation or pins and needles like feeling in the distribution of the nerve, and that is called as the Tinel sign, which is also sign of a regenerating nerve. If there is a nerve damage and axons are getting regenerated, at that time that patient may have a pins and needles like feeling, pricking type of feeling felt at the area when there is some pressure or hitting on the area as such. Then Trendelenburg sign is another of the sign which is often seen in case of patients with the impairment of the gluteal nerve, or maybe the sciatic conditions also, sciatic as well as the gluteal nerve pathology. When the patient is asked to walk on the one leg or stand on one leg, there will be a deviation to the side. And this also can occur in case of the spinal cord pathology. This is also called as a Trendelenburg sign. Of course, most of the signs and details we will be discussing when we discuss the individual diseases later on. Trombone sign is again seen in patients of Korea, where the patient's tongue may be unsteady when the patient protrudes the tongue out. The tongue may not be in a single position, it feels like tremors, like moving here and there when the tongue is stretched out. That's called as a trombone tongue or trombone sign as such. That's about certain of the signs. Now, certain of the definitions used in neurological conditions. Again, there are quite confusing words like so. From the point of view of clarification in the beginning, when we go into the topic later on, you may come across these words quite frequently. That's why I have selected a few of those commonly used words in the neurology, which often can sound similarly, maybe sound very awkward, and they may actually there is nothing complicated. The meaning is simple. But their actual definition should be clearly known. So that's why I have listed a few of such words where the definition is required. Apoplexy is a common word used in neurology, which is produced, is defined as bleeding in an organ or loss of blood flow to an organ. So if there is a sudden loss of blood flow, that's called as apoplexy, and it could be in any organ, not necessarily in the neurological condition, adrenal apoplexy, bleeding in so on. Many times the stroke is also called as apoplexy. The stroke, of course, we will be dealing with the stroke in detail next asset, where there is a sudden onset of neurological deficit, but which is produced due to bleeding into the area. That's called as apoplexy. Stroke could be of different sorts, ischemia as well as the hemorrhagic. Hemorrhagic stroke is called as may be called as apoplexy, but not the other way. So that's one of that definition issue. Then cataplexy is another word where the patient may have a sudden fall due to the loss of muscle tone, which could be precipitated due to sudden changes in the mood or even the narcolepsy. Narcolepsy is a sudden attacks manifesting in an uncontrolled urge to sleep, feeling sleepy, and due to the sleepy feeling, if somebody falls suddenly with the muscle tone being reduced, that's called as a cataplexy as such. So again, these words do not have much significance, but you should know about the exact meaning. Word encephalitis means inflammation of the brain and brain stem structure. Encephalopathy means dysfunction of the brain. The word epilepsy is recurrent seizures, and the seizures definition is when the patient have temporary loss of consciousness. Then mononeuropathy is if there is a dysfunction of individual nerves. Mononeuritis multiplex is dysfunction of multiple single nerves. Myelitis is inflammation of the spinal cord. Myelopathy is dysfunction of the spinal cord. Myopathy is a primary muscle disease. Myositis is inflammation of the muscles. Now, I think these words, they look or sound similar, but each of these words would have a definite meaning as such. Neuropathy is a dysfunction of cortical or cranial or spinal neurons. Neuronopathy is a dysfunction of the cortical, cranial or spinal neurons, whereas neuropathy is dysfunction of the cranial or spinal nerves alone. So cortical or central neuropathology is often considered as a neuronopathy, whereas neuropathy refers to the peripheral. Then polyneuropathy is a bilateral symmetrical ascending or stalking in glow conditions, which is or descending dysfunction of the peripheral nerves. So polyneuropathy, where the tracts are involved, that's called as a polyneuropathy. Radiculopathy is when the nerve roots are affected, that's called as such. Now seizure, that's initially with the apoplexy we have referred to that issue. Subjective or objective behavioral manifestation of an abnormal and excessive electrical discharge in the CNS, that's called as seizure. So seizure is not simply unconsciousness, there could be abnormal behavioral manifestations in a patient. So epilepsy and seizure. Epilepsy, there is a complete loss of consciousness. Seizure is whether there is a loss of consciousness or not, but there is a the abnormal behavioral manifestation seen as such. So anosognosia is a neurological condition where the patient is unaware of the neurological deficit or psychiatric condition, and it's usually associated with the mental illness. So patient may have a neurological condition, but he is not aware of it. That condition is called anosognosia. These are certain of the definitions related to the neurological conditions, somewhat important from the basic understanding point of view, and where usually the students get confused. The next part is about the investigations related to the neurological conditions. Investigations could be many, and in many of the neurological conditions, you may have to go for the investigations as such. Though clinical examination may help to make out the diagnosis in majority of the cases. A detailed clinical examination is always superior to any of the investigation, but still you may need to have a specific investigation to make the diagnosis in a specific condition. And the specified neurological, these investigations related to the neurological conditions are CT, electroencephalogram, MRI, electrodiagnostic tests such as electromyography or nerve conduction velocity studies, and positron emission tomography or PET scan, arteriogram or angiogram, spinal tap or lumbar puncture, evoked potentials where you stimulate the nerve endings, then myelogram, neurosonography, which includes the transcranial Doppler also, ultrasonography, the usual sonography also could be used. Neuroimaging is one of the developing branches now. In radiology, neuroimaging has become a developing branch and has developed very rapidly now, and which involves multiple sets of investigations to study the function as well as the structure as such. So structural imaging with the functional imaging, these are the two important aspects of the neuroimaging technique, and neuroimaging now has become a separate branch in the neurology. So lots of new technologies are coming up, and it's a combination of multiple set of the investigations. Though I will not go into detail of each of these, just I will try to make a brief list of these investigations and certain specialities. More specific, like in which condition, which of the investigation would be suitable, that would be we will be dealing with when we go into the specific diseases. So for the present, I will just have a simple, very basic introduction to the techniques. Computerized tomography is that technology which we have already referred to in case of the radiology discussions earlier, and it's a advanced technology of X-ray where you will have multiple sections of the body taken and computer assists that. The technology was invented in somewhere in 1970s, late 1970s, and within a few years it has become very popular, and now you have lots of permutation and combinations of that. Particularly, it has become revolutionary in case of the imaging of the brain. Till the CT scan was evolved, having an imaging study of the brain was virtually not possible. All that would be because plain X-ray, you will not have that image of the brain. With the ultrasonography, the reaching to the brain was not possible. Rather, getting the image of the brain was not possible at that time. And hence, in 1970s, when the CT scan was invented, it was considered that the neurological conditions can be completely solved as such. And particularly, whenever there is a lesion, suspected difference in the density of the tissues, density of the brain tissue, either like a tumor or a clot or maybe a dead tissue, that can be made out with the CT scan better. Moreover, abnormalities of the bones of the brain, skull abnormalities also can be made out with the CT scan as such. MRI scan is another advanced technology beyond that CT scan, where the magnetic activity is received over the X-rays, and this is very specifically used in case of the soft tissue abnormalities. Variations in the density of the tissues in the brain tissue can be better made out by the MRI scan, whereas the bone injuries, they may not be very clearly seen in MRI. So MRI is specifically indicated whenever there is a suspicion of a soft tissue pathology. Of course, more detail like in which disease condition CT is better, in which condition MRI is better, that part we will be discussing when we go into the specific disease conditions or specific clinical status. Then the functional MRI is another newer development in the neuroimaging. And in the functional MRI, it's a basic MRI. Along with that, the study of the blood flow also can be made out. So along with that soft tissue density, the blood flow to the area can be made out, and hence it's better seen or better understood to differentiate between a benign and a malignant tumor pathology. In the tumor pathology of the brain, the MRI is better than CT, and there again, if you have to confirm like whether there is a possibility of malignancy or a benign conditions, a functional MRI is one of the options as such. Then PET scan or positron emission tomography is another of the technique where the positrons emitted from the tissue is studied, which gives you even the idea of metabolic rate of the tissues. So a tissue where the metabolic rate is high and the area where the metabolic rate is low, that can be made out, and hence it is quite useful to make out that difference between benign and malignant. Moreover, in case of the functional lesions like that of the epilepsy-like conditions, certain of the epilepsy conditions, PET scan can be quite useful to locate the focus of epilepsy as such. That's one of the investigation. Then in the SPECT analysis, in the PET again you have further that SPECT is a single photon emission computed tomography. It's also an advanced technology where the photon emission is received and converted into an image, and this again is very useful in making out the slight difference in the metabolic activity of the tissue. So it's much more specific or much more sensitive than a simple PET scan, and it's quite useful in case of oncological treatment in the patients who are on oncological treatment, like whether the treatment has produced a regression of the tissue or not, regression of the growth or not, or whether the regime which is used in oncological treatment has really changed the condition in the tissue or not. That can be made out with the SPECT analysis as such. Then one more of the specific neuroimaging technique is diffusion tensor imaging or DTI technology, and DTI technology is mainly assesses the water molecule diffusion in and its directions. So particularly brain edema conditions where the patient may have an edema in the brain, that can be made out with the DTI technology. Of course, DTI technology has the access now is not so frequent, not so easily available. Only a very advanced centers have that DTI technologies available. Nearby here, only AJ hospital has DTI imaging technique. No other hospital has it. So anyway, maybe in due course of time, this technology also become popular, and particularly in the patients where you suspect edema of the brain tissues, and like post-traumatic after the trauma or post-surgery. If you have to assess the neurological condition, DTI is often preferred. Cerebral angiography is, as in any other angiography, you inject the radiopaque dye into a blood vessel and identify or picturize the blood distribution, vessels distribution. So vascular abnormalities, either structural or maybe a blockade of the vessels, that can be made out. Angiography. Now, of course, angiography has become a common technique for any other organ of the body. Coronary is very more popular. Cerebral is the next as such, quite frequently used as such. The neurosonography is very specifically used in antenatal or neonatal conditions, intrauterine life, abnormalities of the intrauterine life, or immediately after the birth, neonatal conditions. Neurosonography is used, and particularly it's used for evaluation of the congenital abnormalities of the brain antenatally, or for diagnosis and follow-up of intracranial hemorrhage in neonatal conditions, intracranial ischemia, hydrocephalus, or extracorporeal membrane oxygenation patients, like where the patient may have hypoxia-like conditions, or congenital infections, intracranial neoplasms of the neonatal conditions. They are now better made out with neurosonography, because neonatal conditions CT or MRI would not be possible easily, and antenatal, of course, it's only the neurosonography which can be done. Lumbar puncture and study of the CSF is one more of the investigational tool, particularly in case of meningitis or encephalitis inflammatory conditions, or if there is a suspected subarachnoid hemorrhage where the CT doesn't show that, or treatment monitoring in case of the hematological or malignant neurological disorders where a drug may be injected into the intrathecal route, or spinal anesthesia also. Lumbar puncture is one of the common techniques. Myelogram is where you inject a radiopaque dye into the subarachnoid space, and the flow of the CSF is studied, and whenever there is a blockade of the CSF, the particular integrity of the spinal canal can be made out with the myelogram. Of course, when we go into the disease conditions, we will see more of these examples. Then another very specific is a nerve conduction study. Nerve conduction study could be again the same instrument could be used as a these neuromuscular studies as well as conduction of the nerves, and it's a technique where you have two electrodes, and from with the electrodes you stimulate the nerves at 2 points, distal and proximal, and the time taken for the conduction of the impulse is studied, and you get a graph, and it could be of different sorts. Abnormalities can be seen, and the abnormalities could be of the normal. There will be a time gap as such. Abnormal there when the sheath of the muscle has become sclerosed as such, you will have the jumping waves, abnormal waves as such, and if there is a axon degeneration, there will be no waves or very low waves could be seen as such in such nerve conduction studies as such. And the signs would be of either axon loss or diffuse myelination or focal demyelination signs would be seen in such conditions as such. Of course, it also helps in identifying the same technology, slight modification in the position of the poles and the study technique. It also can be used for identification of the muscle pathology. Then it's called as electromyography, EMG or NCB studies, neurological conduction study or EMG. The instrument is same. The only difference is in the technique of positioning of the nodes and their observations. Now the differences would be in case of nerve conduction studies, as you introduce initial waves, the initial stimulus, a normal stimulus would produce a typical wave of short duration in the nerves as such. A lower motor neuron pathology, you will have an increased response. Upper motor neuron pathology, there may not be much of a change, it may look normal. In case of myopathy, the stimulus initially normal, but polymyositis, it will be increased. So that by looking at that pattern of the waves produced on first stimulation, you will be making one possible diagnosis. Similarly, when you give a continuous stimuli, spontaneous activity is seen, then there will be a fibrillation produced in case of lower motor neuron pathology, whereas in other conditions may not show the changes. In even case of polymyositis, there will be a fibrillation, similar condition as that of the lower motor. Then if you assess the current flow, the intensity of the current flow, in the normal there will be a typical action potential formed with a small depression and then a peak wave as such. Whereas in patients of lower motor neuron pathology, you will have a wider distribution of this. The total activity will be longer, wider as such. And in myopathy, the whole activity becomes shorter, and amplitude also becomes shorter. In myopathy and polymyositis, that amplitude becomes lesser. If if the conduction is stimulated and then it is a block, like you have that setup in that where you can block the conduction immediately, the responses in case of normal, there will be patchy response, continuous contraction of the muscle. If in a lower motor neuron, the response will be fast firing, like it will be repeated these activities, something like fibrillation like activity will be seen. In upper motor neuron, there will be reduced rate as such, whereas myogenic conditions, there may not be any change as such. That's about that. Of course, more and more details of that we will be discussing when we go into the next phase, that individual disease conditions. Then another very popular and very specific investigation related to the neurological condition is electroencephalogram or EEG. EEG is by keeping electrodes on the multiple areas over the skull. You record the waves produced, and depending upon that pattern of the waves seen in a specific lead, you make out the diagnosis. The basic issue, again I will not go into the detail of the EEG now, but a basic issue is identifying the pattern of the waves. The waves produced are mainly categorized into 5 categories based upon their amplitude and the intensity. Mainly the frequency is the main issue. The gamma waves are those waves which have a high frequency as such. Alpha waves are those which have a frequency of 8.13 as such, and beta waves are those which have a greater than 13 hertz as such, and delta waves have a lower frequency as such. So this way the waves are identified by their frequency and their pattern, and by looking at these features you generally make out the diagnosis. And what these waves interpret would be: alpha waves are seen in all age groups and must primarily in adults, and they occur rhythmically in the head area, and the usually you can make out like which side of the brain is dominant or which side of the brain is less dominant. The above usual average is left brain is more dominant, and that's why you use your right hand more frequently than right handed, like such conditions. And that kind of difference is seen in the production of alpha waves in the different zones as such. And it also can change according to the mental attention, like when you are doing complex jobs like calculations or attending the classes, etc. The alpha activity disappears, alpha waves will disappear, and then it's called as a normal. Abnormal is a coma conditions. The alpha activity will be hypoxic, or in hypoxic conditions the alpha activity will be seen as a flat uniformly, and both the sides it will be uniform, and it doesn't change according to the stimuli. Say particularly when you give a external stimulus, alpha wave pattern will be changing, but in the patients where there is a severe coma or the activity of the brain is reduced, there will be no response. Beta waves are they again seen in all age groups, and they usually have a small amplitude and usually are symmetric. They are present throughout. Drugs like benzodiazepines, barbiturates, etc., they will enhance these beta wave pattern. Theta waves are seen usually in age group, sleep as such. In awake adults, these are waves may be abnormal, and they could be suggestive of attention abnormalities, and they are also called as slow waves. Delta waves, these also are slow waves, and they are normally seen in deep sleep in adults, and they have a large amplitude of all waves as such, and they could be suggestive of local pathology, particularly in case of epilepsy-like conditions. Delta wave activity is one of the issues. Of course, more specific pattern in specific disease conditions, I try to show that examples later on when we go into the disease-like conditions. General indications for the EEG are particularly to identify and classify the seizures and their locations, like whether there is a focus or not. Then you may have augment this EEG with the sodium aminobarbital, which is also called ADA test, to study the level of intellectual activity, particularly dominance of memory in those patients who have abnormal psychological behavior, to see whether there is an abnormal nerve conductions impairment or whether there is a structural impairment that can be made out with the EEG. Then in the patient of status epilepticus, when you induce the therapeutic coma in a state, to control, like to evaluate like whether the induced anesthetic drugs would be producing a reversible damage or irreversible damage. So monitoring that patients in a status epilepticus, when you manage with the anesthetic drugs, the EEG is must, it's a mandatory. Then patients with the mental abnormalities, particularly to differentiate the causes of the mental abnormality, particularly toxic pathologies. Then patients with the unexplained etiology of encephalopathy, patients who have different diagnosis of encephalopathy and their signs we will be discussing later on. Patients with the syncope or loss of consciousness with the negative cardiac outcome. There is no cardiac pathology, but patients have syncope. In that condition, EEG may be necessary. Comatose patients also, in intensive care patients, it may be necessary to assess the responsiveness of the patient. Cardiac arrest patient or brain death determination. In both conditions, EEG is another essential criteria to confirm about the possible brain activity left over, and ischemic changes of the subarachnoid, intracranial hemorrhage, as well as anesthetic procedure to identify the deep of anesthesia. Also, EEG may be necessary. These are certain of the indications for the EEG. The normal EEG, seizure-free ECG, and then the epileptic seizures, as well as certain of course, I will be dealing with somewhat more detail when we go into the epilepsy conditions as such. Of course, this part again we will discuss when we go into the epilepsy pattern as such. I think with this we will conclude today. Next we will start with the disease conditions related to the till now whatever is done as a basic introduction to the neurology. Next we will deal with the disease conditions, and I would prefer to start with the stroke in the beginning than really the other conventional methods. The conventional neurology starting with the other disease, simple diseases, but because we are dealing with the stroke conditions more frequently, and with that order, I will be dealing with the stroke in the next session. And if there are any questions, I will try to answer, and then otherwise you will wind up. Right? There are no questions. So, okay. So next we will start with the stroke, its diagnosis, and the gradual further progress into the disease.